So now we have a way to translate the statements that injured workers give to us regarding their pain and how that pain is impacting them in their life. We now have a way to translate their descriptions into something that we can use in the workers' compensation system, into a language that we can apply to our reports and apply to the AMA guides in an effective and accurate manner to come up with conclusions that are substantial medical evidence. And we've explained and gone into detail about how injured workers and people in general, and I know I've done this before, but how injured workers specifically can misstate or perhaps overstate their level of symptoms, because of course injured workers aren't familiar with language and descriptions that are specifically defined in the workers' compensation system. So we've gone over some methods to put into proper perspective the level of pain and the level of impact that pain has on the ability to perform activities of daily living. And now we want to shift gears a little bit and go into some additional topics that are along the same lines and the same themes, but that slightly differ, because we're going to go now into some discussion of malingering and symptom magnification. And unlike cases where injured workers may overstate or overdefine their levels of pain out of ignorance of the true meaning of those words, when we get into discussions of symptom magnification and malingering, implied or implicit in the concepts of symptom magnification and malingering is conscious and willful and intentional deceit, which is a different item altogether from simply overstating or over-describing symptoms. Now, terms common in the workers' compensation arena that deal with examinee presentation and perceptions of pain include malingering, include symptom magnification, include symptom amplification, include deception, include somatization, and there are other terms as well. The balance of this discussion focuses on topics relating to malingering, symptom amplification, and deception. So let's define some of these terms. Merriam-Webster Dictionary defines malingering as to pretend or exaggerate incapacity or illness, such as to avoid duty or work. So that describes a particular reason or intention or purpose for the exaggeration of the incapacity or illness. It describes some motive. In this case, according to Merriam-Webster, the motive is to avoid duty or work. And in this example, I believe they're talking about military duty. According to the Diagnostic and Statistical Manual of Mental Disorders 4, the DSM-4, malingering is defined as the intentional production of false or grossly exaggerated physical or psychological symptoms. You notice the word they're using the term physical symptoms and or psychological symptoms, motivated by external incentives such as avoiding military duty, avoiding work, obtaining financial compensation, evading criminal prosecution, or obtaining drugs. Let me repeat that. According to the DSM-4, malingering is defined as the intentional production of false or grossly exaggerated physical or psychologic symptoms motivated. Notice here that there's a motive. It has to be a motive. motivated by external incentives such as avoiding military duty, avoiding work, obtaining financial compensation, evading criminal prosecution, or obtaining drugs. Now, which of those components of that definition would we see perhaps in the workers' compensation system? Well, are there external motives in the workers' compensation system, such as avoiding work, such as obtaining financial compensation, such as perhaps obtaining drugs? Now, in the workers' compensation setting, this amounts to a deliberate and a fraudulent feigning of symptoms. A deliberate and a fraudulent feigning of symptoms. Now, important in understanding malingering is the fact that claims of symptoms, impairment, and disability are willfully, intentionally, and deliberately overstated. It's willful, it's intentional, and it's deliberate, and it's motivated by What about deception? Well, Merriam-Webster defines deception as to cause or accept as true or valid what is false or invalid, to give a false impression. That's a quote. To cause or accept as true or valid what is false or invalid, to give a false impression, unquote. Now, deception may include statements or physical acts. Statements or physical acts, the purpose of which are to propagate beliefs that are not true or are not the whole truth. This may include omission or withholding of information. And there's two types of deception. There are acts of commission, which would be outright lies, outright lying. That would be an act of commission. But probably more common are acts of omission, withholding of information, not saying some things. And in my experience, it's what's not said that is often more telling than is what's said, because many times acts of omission are the more common method by which deception is used. So it pays to pay attention to what's not being said, what's missing, what's wrong in this statement, what's absent. And many times you'll find that what's absent from statements or physical acts are the emotions, because false statements and false physical acts are devoid, because they're false, they're devoid of the emotion that would normally accompany a true statement or a true physical act. So this is given to you and this is explained to you to quicken your thinking to perhaps what might be missing from any statements that are given to you or any physical acts that you observe, both in the QME interview and also in the QME examination. You might think to yourself, what's missing here? Symptom magnification. Symptom magnification is defined as the patient exaggerating or magnifying their actual complaints in order to, quote, sell, unquote, the doctor on the truth of their claims. So we have these three different categories of overstatement or misstatements of physical conditions, and that is deception, that is symptom magnification, and malingering, finally, which is the out-and-out willful, deliberate misleading of the doctor. Let's talk a little bit about malingering and go into more detail now about malingering. The DSM-4, the Diagnostic and Statistical Manual of Mental Disorders, describes 4 criteria for malingering. And they include, number 1, a medical legal context of presentation. The presence of a medical legal context. Number 2, a marked discrepancy between the stated level of disability or impairment and the history. A marked discrepancy between the stated level of disability or impairment and the history. What history? Well, the medical history as it's described in the medical records, the history as it's described to you by the examinee, the history involving the mechanism of the injury, and other components of history that may not be consistent with the apparent description of your injured worker of marked disability or impairment. Number 3, the third criterion described by the DSM-4 would be a history of lack of cooperation. And that could include lack of cooperation either with the diagnostic evaluation, meaning the examination that you are now conducting, or a lack of cooperation with prior prescribed tests and or prior prescribed treatments. And I'll give some examples of those as we go. Criterion number 4 would be the presence of antisocial personality traits and or the presence of an antisocial personality disorder. And we'll go into those one at a time. Now, the DSM-4 states that the presence of 2 of the 4 criteria suggests probable malingering. Probable, not possible, but probable. The presence of 2 of the 4. Number 1 was medical legal context. Number 2 is a marked discrepancy between the claimed impairment and the medical history. Number 3 is a lack of cooperation with either the exam or prior treatments or prior testing. And number 4 is the presence of antisocial personality traits or antisocial personality disorder. So the presence of any two of those 4 suggests probable malingering. Now, the DSM-4 has been criticized, and these definitions and these criteria are not absolute. However, in my opinion, the 4 criteria are useful guideposts that the evaluator can consider when assembling the final conclusions on permanent impairment. And based upon the above criteria, let's go now into what some examples would be of each of the criteria described in the DSM-4. And before we do that, an interesting question becomes, in the workers' compensation system that we're involved in, which of the 4 criteria are already present, are already or most likely already present? Well, of course it would be criteria number 1, the medical legal context. Because all examinees find themselves in the workers' compensation system, all examinees can be considered to meet at least criteria 1, the medical legal context. All examinees find themselves either willingly or unwillingly in the medical legal context of the workers' compensation. Therefore, you can expect in advance, that examinees may overstate, number one, their symptoms, and number two, the impact of those symptoms on their ability to complete activities of daily living. Just the very fact that the examinee showed up to the appointment indicates that they want to convince you as the evaluator of something. The question becomes, what is that something? In my experience with thousands of injured workers, very few come to the appointment to convince me that they are 100% better and are completely recovered from their injuries. Very few come to the appointment and state, you know, because of the physical therapy that I had, I'm in even better and stronger shape than I was before the injury. I'm so good now that I'm the high scorer on my ice hockey team. Now, I've had a few of those examples where injured workers have come to tell me that they're completely well, but again, that's just very few. The opposite is more often the case, as injured workers come to the appointment to report their problems, and as the evaluator, it's important to put the reported problems into the overall context of the case. Examinees will report problems with their injury. They'll report problems with their condition, problems with their employer, problems with their family, problems with their finances, problems. Now, problems are a normal and natural part of life. And in this setting, be alert for problems that are out of proportion to the mechanism of injury and far outside of what would be considered a normal healing response in an otherwise healthy person. An example from my recent files that raised my suspicion for quote-unquote marked discrepancy involved a 52-year-old male who we'll call Mr. Jones, who at the time of the injury was on the second step of a 3-step step stool. Okay, so Mr. Jones was arranging paper cups and paper plates on a shelf in kitchen cabinets when he lost his balance and stepped down to the ground, a height of approximately 2 feet below the second step of the step stool. And he landed somewhat awkwardly on his left leg. He did not fall. He simply landed kind of with the majority of his weight on his left leg, and it was a little bit awkward, but he did not fall to the ground. He simply landed awkwardly. Well, he didn't think much of this, and he continued working for the balance of the day. Next day, he woke up with pain in the lower back, and he reported this to his supervisor. Medical treatment was arranged, and medical providers diagnosed him with lumbar sprain strain. He was given the next day off to rest his back, and over time, pain did not resolve, and the primary treating physician provided return to work recommendations of, quote, no lifting over 10 pounds, no bending below waist level, and no standing greater than 20 minutes, unquote. These were restrictions that the employer was not able to accommodate, and so Mr. Jones stayed at home on total temporary disability. Remember, the mechanism of injury was a step down from a step stool of about 2 feet in height. The diagnostic studies, including lumbar spine x-rays, lumbar spine MRI, and lumbar spine and lower extremity electrodiagnostic studies, were significant only for age-related degenerative changes of the last 2 segments of the lumbar spine. This was a 52-year-old male with age-related degenerative changes of L4 and L5. 6 sessions of physical therapy did not help. Injection to the right sacroiliac joint did not help. 3 series of selective nerve root blocks did not help. 6 sessions of chiropractic did not help. Thus, the combined suggestions and recommendations of 1, the primary treating physician, 2, a physical medicine and rehabilitation specialist, 3, an orthopedic surgeon, 4, a physical therapist, and 5, a chiropractor, did not help to bring about a resolution of Mr. Jones's lower back pain symptoms. And when I evaluated Mr. Jones for a QME for the second time, he reported continued worsening of his back pain despite 15 months of total temporary disability. He presented to the evaluation without a cane, without a brace, and without any type of assistive device. Physical examination demonstrated normal lumbar spine and normal lower extremity neurologic function. Lumbar spine range of motion was limited in all ranges due to report of lower back pain. And I concluded that this was an example of a disability that was way out of proportion to the mechanism of injury and the physical examination findings. And because criteria 1 above, which is the medical legal context of presentation, was already met due to the medical legal context of the evaluation, combined with the fact that this was a represented injured worker, the presence of a marked discrepancy between the claimed disability and the objective findings establishes 2 of the DSM-4 criteria and could lead the evaluator, in this case was me, but it could also lead you to the possibility that malingering and or symptom magnification could be present. Did I say was present? I did not say was present. I said that it could be present. DSM-4 says that the presence of 2 of the 4 suggests probable malingering. And so in the case here of Mr. Jones, we have at least 2 so far. We have a medical legal context and we have a marked discrepancy. If we go back to the Webster's Dictionary definition of malingering, could it also be said that there is some external incentive or motive, such as to avoid duty or work? Or if we consider the DSM-4 definition of malingering, could we consider that there was an external motive, such as avoiding work, obtaining financial compensation, or obtaining drugs? Is that possible? Well, according to DSM, it's probable if 2 of the 4, and I'm not going to take a committed stance either way, except to say that the presence of these 2 in this particular case led me to suspect that malingering could be present. The third criterion is a lack of cooperation with testing or treatment. And an examinee who's malingering may not cooperate with medical providers. Oh, they're not overt about it, they're subtle about it, but it's not hard to detect a lack of cooperation when it's present. Now, the DSM-4 describes lack of cooperation as occurring both with the diagnostic evaluation, which is meaning your QME examination, and 2, with the prescribed treatment program. So in the workers' compensation setting that we're involved with, the diagnostic evaluation, that can include various evaluations and testing with specialists and other outside facilities, and it can also include the QME evaluation itself. And the lack of cooperation is an effort to avoid or to confound procedures that would reveal a lack of true objective findings. The examinee may also not cooperate with the prescribed treatment program. So let me give you some examples of lack of cooperation that may indicate malingering. Let's talk first about the diagnostic evaluation, which is both evaluations and testing with various specialists and outside facilities, and also your QME evaluation. So here's a few examples. Number one, the examinee states that they're unable to complete MRI studies because they're too apprehensive and too claustrophobic to enter the MRI tube. That could be an example. Is it a definitive example? No, but it could be an example. Number two, X-ray or MRI studies are significant for motion artifact, even though the examinee was instructed to hold still. Number three, the examinee becomes quote-unquote unavailable for appointment days, dates, and times despite being on total temporary disability. Number four, the examinee comes to the QME appointment late, causing the appointment to have to be rescheduled for a later date. I know that's happened to me. Has that happened to you? Does that mean that the injured worker is malingering? Not necessarily, but it could. It could be a sign combined with some of the other signs, especially if there's prolonged total temporary disability involved. A delay in the QME appointment could be a way of obtaining financial compensation. That could be consistent with the DSM-IV criteria. Number five, the examinee comes to the QME appointment without completing required paperwork, despite being reminded prior to the appointment to complete all paperwork. That could be a sign of lack of cooperation. Does it mean that there's malingering present? Not necessarily, but it could. Number six, during the examination, and this is just one example of an examination lack of cooperation, the examinee refuses to allow manipulation of the legs, as in straight leg raising or passive hip flexion testing, despite being observed to walk normally and to sit comfortably. That would be an observed inconsistency and a lack of cooperation with the diagnostic evaluation. What about lack of cooperation with the prescribed treatment program? Number one, the examinee fails to take the prescribed medication for a variety of stated reasons, such as stated side effects to the medications. Frequently, medications are changed, but still the examinee finds the medications intolerable. So, might look for examples where the examinee has a variety of medications, but they all seem to be unacceptable. That could be an example of lack of cooperation. Number two, the examinee refuses invasive procedures such as epidural steroid injections or surgical procedures despite claimed inability to work and marked impact of the reported condition on activities of daily living. The examinee may state that they, quote, they know a friend, unquote, who had a similar procedure or surgery or a similar treatment who, quote unquote, ended up worse as a result of the procedure. And for that reason, they don't want to participate in invasive procedures, although they're more than happy and willing to continue with conservative treatments, even though those conservative treatments have failed to provide a resolution of the problem, and despite the fact that they're suffering badly and unable to work, they still refuse these procedures that are expected to possibly help them. Does that indicate malingering, a lack of cooperation with prescribed treatment program? Not necessarily, but it could. Number three, how about the examinee who quits physical therapy after 2 sessions, stating that the therapy, quote, made me worse, unquote? How about the examinee who reports new or additional symptoms as a result of the physical therapy, stating that the therapy made me worse? Same situation could also go for those who quit chiropractic treatment after 2 sessions, stating that the chiropractic made me worse. The examinee may report new additional symptoms as a result of the chiropractic treatment. And with regards to physical therapy and chiropractic treatment, doctors I see this all the time in my medical records and examining my injured workers, where injured workers claim or state that the therapy made them worse and they discontinued. And I don't know about you, but having been a chiropractor for 25 years and rendering treatment to thousands and thousands and thousands and thousands of people, including injured workers, I'm used to seeing people get well with treatment. I'm not used to seeing people that get new additional bad, worse problems as a result of treatment. So when I see this lack of cooperation or this adverse result in the medical records or in the statements of my injured workers, to me, this raises a red flag. Does it mean that it's not true, that it's not possible that poor treatment could make a person worse? Of course, poor treatment could make a person worse, but in my experience, treatment generally makes people better. So it could indicate malingering. It doesn't necessarily, but it could. Finally, would be an examinee who quits acupuncture treatment, reporting no help or worsening as a result of the acupuncture treatment. Okay, and then criteria number 4 from the DSM-4 would be the presence of antisocial personality traits, or the presence of an antisocial personality disorder. Now, a determination of the presence or absence of antisocial personality disorder is outside the scope of most evaluators, because that's the realm of psychology and psychiatry. However, awareness of some of the characteristics of the antisocial personality can sharpen the evaluator's thinking to the possibility of malingering. Excuse me. According to the DSM-4, the antisocial personality is characterized by, quote, a pervasive pattern of disregard for and violation of the rights of others that begins in childhood or early adolescence and continues into adulthood, unquote. Let's do that again. This is according to the DSM-4. The antisocial personality is characterized by, quote, a pervasive pattern of disregard for and violation of the rights of others. Disregard for and violation of the rights of others that begins in childhood or early adolescence and continues into adulthood, unquote. Now, antisocial personality disorder can be suggested in 1, the medical records, 2, in the employment records, and 3, in the physical examination. And I'll give you some examples of those. In the medical records and or the administrative records, which could be employment records. I get employment records as part of my records all the time, and I review those, and I look for these signs of antisocial personality disorder. And it doesn't have to be a big deal. You don't have to make a big deal out of it or make it a formal thing. You just look for trends that demonstrate the signs of anti-personality traits. So an example would be truancy. Truancy. Late for work, missing work, late for medical appointments. You would see this in the medical records. No-show medical appointments. Sometimes you'll see indications that the injured worker was a no-show and seemed to have disappeared or suspended treatment. Number 2 would be examples of lying and or stealing. Those are examples of disregard for and violation of rights of others, lying and stealing. Number 3 would be substance abuse, either prescription medications or recreational drugs, street drugs. Number 4 would be a history of depression, possibly including a suicide attempt. 5 would be history of arrest. 6 would be use of aliases or other names. One of the antisocial personality traits is the use of other names, also known as aliases. In the physical examination, you may see some of the same things. You may see that the examinee is late or a no-show for the QME evaluation, or during the physical examination, you may see that the examinee displays what's known as superficial charm. Superficial charm. Superficial charm is one of the traits of antisocial personality disorder, and examples of superficial charm include an examinee who's very engaging, an examinee who's very charming, an examinee who's very slick and flowing and even funny at times, and an examinee who's very verbally facile, very quick, very socially charming, the so-called superficial charm. Now, according to the DSM-4, 2 of the above criteria suggest malingering and or symptom magnification. Now, all examinees present with criteria 1 because all examinees present with a medical legal context by virtue of their involvement in workers' compensation. The exception to this would be an examinee who presents to the evaluation stating that they're fully recovered from their injury, and they're simply at the examination because it's their understanding that the examination is part of the conclusory process of the claim. I've had these cases, but again, they're very few. Heightened concerns for malingering are those examinees represented by an attorney. That would confirm sort of a second level or a second hierarchy of a medical legal context of presentation. So most, if not all, examinees fit criteria 1 for the possibility of malingering, and the history and physical examination then would reveal the presence or absence of 1 or more of the remaining 3 criteria. Thus, the importance of the face-to-face evaluation. And injured workers you're going to find that injured workers have 2 basic ways that they can exaggerate their disability. Number 1 is by overstating their symptoms during physical examination maneuvers. They'll say, "That hurts. That hurts." And number 2 is by understating their abilities or their capacities during physical examination maneuvers. They'll say, "I can't do that." So 2 ways, by either overstating or understating. And by the way, this is one of the complaints or concerns with functional capacity examinations, is that an unmotivated examinee will understate their ability on functional capacity exam and not cooperate fully or not be sincere in their effort on the testing maneuvers, and therefore produce an invalid conclusion. So we're going to go into some physical examination maneuvers and situations that could suggest overstatements and or understatements. And before we do that, I want to say also, and just touch back to something that we talked about earlier, that examinees may also overstate their symptoms on symptom questionnaires. As I said earlier, there's no hard and fast objective measure to quantify an examinee's report of pain. It would be great if there was, but there isn't, and so we rely on other measures to assess the consistency of the examinee's complaints of pain and impairment. For example, we ask examinees themselves to quantify their pain and the impact of their pain on the ability to perform activities through the use of questionnaires and outcome assessment measures. Now, these questionnaires need to be thoroughly reviewed because their completion relies completely on the examinee's subjectivity. And earlier I described many of the questionnaires that are described in the AMA guides, such as the Beck Depression Inventory and the Epworth Sleepiness Scale and the Neck Disability Index, etc. And the problem with these questionnaires is that they rely on the self-report of the examinee and therefore are subject to the perceptions of the examinee. And I find only limited use to these symptom questionnaires because of so many contradictory responses on questionnaires, with number one, with what's stated in the medical records, and number two, with what's observed in the physical exam. For example, and classically, this is a classic sign of inconsistency. It's very common for examinees to underreport or understate their ability to sit on the revised Oswestry low back pain questionnaire. And this is just an example, which conflicts with their observed ability to sit during the interview and physical examination. And an additional way to investigate sitting and the ability to sit is to question the examinee as to whether or not they drove themselves to the examination. And I don't know what your procedure in your office is, doctors, but when I schedule an appointment for a new panel QME, I always send the injured worker a package of forms that need to be completed prior to the examination. And included with that package of forms is a map to the examination office, and I get that map right off of a MapQuest. And MapQuest gives me the distance and time, approximate time, from the examinee's home to the examination office. And so I know how long that they have to sit by the time they get to the examination. Now, could the injured worker say that they went halfway and stopped for coffee and then stopped and got out? Yes, that's completely subjective and it's non-verifiable, correct? However, you can couple that information with what you observe during the interview and physical examination and see if indeed there is consistency or inconsistency. Also, limited use of the symptoms questionnaires comes from an absolute lack of ability to corroborate the examinee's stated limitations with their actual limitations. You know, and I gave examples earlier of not being able to go into an examinee's bedroom and observe difficulty with sleeping or difficulty with performing sexual relations. We have absolutely no way to be able to verify those things. It's totally based upon subjectivity. So in my opinion, this makes the questionnaires of limited value other than to highlight possible inconsistencies between subjective reports and observed findings. And that's what I find to be one of the useful components of the questionnaires. Is it's real good at pointing out inconsistencies much more than it is reliable for pointing out consistencies. Now, let's talk about pain behaviors. Pain behaviors are observed in both the interview and in the physical examination. And aside from symptom questionnaires, examinees can give pain indications through nonverbal pain behaviors. And the AMA guides describes pain behaviors on page 580, and examples of pain behaviors that are described in the guides would include facial grimacing. Now, the AMA guides does not elaborate on facial grimacing, but I do here, and I give some examples of facial grimacing. Would include a tense face, would include facial restlessness or tics, and that'll have to be what's the term, differentiated from an actual organic disorder, but facial restlessness could qualify as facial grimacing. There's a grimace, there's the corners of the mouth downwards, could include a look like the eyes are being squeezed, could include a sad look with the examinee almost in a tearful type of state, could include a frightened or a fearful look. You might observe this as a deep nasolabial furrow, deepening of the crevices of the nose and lips. You might observe a trembling chin as if cold or shivering. Those would be examples of facial grimace. Other pain behaviors described in the guides include holding or supporting the affected body part or area. This is commonly seen in upper extremity conditions. Could include limping or distorted gait. Limping or distorted gait. This may or may not be present with an assistive device. And we go into a complete discussion, a 3-hour discussion actually, on gait disturbance and assistive device in another one of our programs. And in that program, I go over procedures to assess the consistency of a limp or a distorted gait, or some sort of gait compensation. I also go into a method for evaluating the medical necessity of assistive devices. So you'll enjoy that program. Includes frequent shifting of posture or position. This may include getting up out of the chair to stand. May include shifting from one buttock cheek to another, perhaps even sitting only on one buttock cheek but not the other. Could include craning and stretching the neck, and it could include upper or lower extremity gyrations. And you've probably seen these in your own experience. And I've seen many, and I'm sure you have, and I want you to take a moment and just position and just picture some of these in your mind. Picture the examinee getting up and out of the chair to stand. And even that process itself can be evaluated for consistency, and I'll go over some of those examples here shortly. Everything has to be evaluated for consistency. And for example, if you see craning and stretching of the neck, is that consistent with the cervical spine exam? And is it noted to be consistently present throughout the interview and examination? Is it noticed to be present at times and absent at other times? All of these have to be evaluated for consistency. Also described in the AMA guides as pain behaviors would be extremely slow movements. Again, we observe these for consistency. Sitting with a rigid posture, is that consistent with the history? Is it consistent with the mechanism of injury? Is it consistent with other behaviors noted throughout the interview and examination procedure? Moving in a guarded or protective fashion, is it consistent? Moaning, or other verbal indications of pain could include sighing, yelping, crying. I recently had an injured worker that cried out loud just as hard as if her dog had just died. Could include groaning. It could include sounds of restlessness. And again, these things need to be taken in context for consistency. Crying out loud could be a sign of bona fide pain. It could be a sign of symptom exaggeration. It depends on your conclusions, doctors. It depends on what you conclude based upon your total analysis of the whole case as a whole. The use of an assistive device such as a cane, a cervical collar, or other device. Doctors, in my opinion, just on the topic of assistive devices, in my opinion, in order for an assistive device to qualify as a medically necessary device, first of all, the device must be prescribed by the primary treating physician or other specialist, or possibly even the primary care physician in certain circumstances. But it must be medically prescribed and not self-procured. Number two is that the device must be properly fit to the person, taking into consideration their size and their body habitus and their particular measurements. And number three, the person must be instructed on the proper care and the proper use of the device. And many times these two final factors, the proper fit and the proper use and care, these are omitted. And remember, we talked about omissions as signs of deception. These are omissions. These are factors that you won't find in cases where these devices are self-procured. You won't find a written prescription. You won't find that the device fits properly. It might be an improperly fitting device, such as a poorly fit cane or an improperly fit lumbosacral support belt. And the injured worker will not be instructed on the proper use because there was no doctor to instruct them. They simply self-procured the device, and this is common with canes, and you'll see injured workers that use canes improperly. In fact, they'll even use the cane in the wrong hand. So this is another area where you can assess for consistency. Sometimes they'll have a stoop while walking, especially in the case of claimed lower back pain. And there'll be other physiologic signs as well. These are not described in the AMA guides, but I give them to you here. Could include breath holding, faltering respiration or shocking respiration, sort of as a young child would hold their breath and stutter with their breath when they cry. They could have a red look on their face, or they could turn red with facial flushing. They could have tears. They could have sweating. And we don't have time to go into sweating here, but I refer you to your basic anatomy textbook for a discussion of the ecrine and apocrine sweat glands and the innervation of those sweat glands. And I just mentioned here that the apocrine sweat glands found in the axilla and the perianal areas are stimulated under stressful situations, and you may find injured workers that are under stress seem to be sweating excessively in the axilla, and that should be something that when observed you would put that into the overall context, and again you would do a consistency evaluation. Now, in my opinion, pain behaviors like symptom questionnaires are also of only limited value because they can be manipulated by the examinee's motive. Now, I discussed distorted gait and the use of assistive devices in another article, which I've referred to here a couple of times, on gait disturbance. In this article, I discuss how to identify gait disturbances in a little bit. We'll get into that shortly. And also how to identify the proper use of a cane or assisted device to determine its true use and true need in the performance of activities of daily living. Now, to me, more reliable than pain behaviors are quote-unquote objective evaluations of the examinee's physical capacity, and this is evaluated in the physical exam, which we'll also get to shortly. In the history-taking portion of the QME examination, examinees can deceive by overstating and magnifying their symptoms, and that's often evident in overstated or exaggerated pain behaviors. In the physical examination portion of the QME, examinees can deceive by understating their ability to complete examination maneuvers. And any inconsistency between the examinee's stated or understated ability and the observed ability could suggest malingering.